Good afternoon. Welcome to the Vasculitis Foundation Roadmap to Wellness webinar series. My name is Joyce Coleman. I'm the Executive Director of the Vasculitis Foundation, and I want to thank you for attending. I am pleased to welcome Dr. Rennie Rhee to the webinar. Dr. Rhee is the 2014 through 2016 Vasculitis Foundation Fellowship recipient. Dr. Rhee began her fellowship this past year at the University of Pennsylvania. Her mentor is Dr. Peter Merkel, the chair of the Division of Rheumatology and the lead investigator of the Vasculitis Clinical Research Consortium and the Vasculitis Patient-Powered Research Network. During Dr. Rhee's fellowship, she will see patients and also work on research in the field of vasculitis. In particular, Dr. Rhee hopes to determine whether outcomes, such as survival and development of end-stage renal disease, are improving in patients with ANCA-associated vasculitis over the past 25 years. Dr. Rhee is also interested in the impact of early diagnosis and treatment advances on these outcomes. Today, Dr. Rhee will be discussing long-term issues in ANCA-associated vasculitis. What's beyond year one? Dr. Rhee, welcome to the webinar.
Thank you very much for this opportunity to talk about long-term issues in ANCA-associated vasculitis. So you're all probably here because you are learners and you're planners. And I myself am somewhat of a planner, and so is my husband. So a few years ago, when I found out I was pregnant with our son, who is now 2, and this is a shameless posting of his picture, we realized we don't know a thing about raising a child. Suddenly we're being entrusted with the care of another human being, so we decided we would try to be as prepared as possible for what lies ahead. So we started to read. We read books written by pediatricians. We read books written by other parents because sometimes hearing the experiences of others who've been through it themselves is invaluable. We also did research, or rather we read the research that others did, and we tried to find the safest products for the best value. And we also learned about day-to-day practical things such as changing diapers and taking a bath. And our main outcome was really to keep our son out of the hospital for the first 3 months and maintain our sanity. And I think for the most part, I'd say we succeeded in meeting some of those goals. But before we knew it, he was a year old, and he was walking, and he was climbing things, and he was talking and saying no a lot. And we realized that we were suddenly confronted with a whole new set of challenges that we just weren't prepared to handle because we had been so focused on just getting through those first few months. And perhaps that's where some of you are today. You got your diagnosis and you are now in remission and you're wondering, well, what lies ahead for me? And so that's what we're going to be talking about today. And I'm going to focus on these 3 main topics. First, I'm going to look back at the past and talk about whether long-term outcomes have changed in the past 25 years. And this is really kind of a lot of the research I did over the past year that was funded by the Vasculitis Foundation. I'm then going to move forward and talk about present situation, what can we do today? And I'm going to focus on 3 main outcomes: relapse, cardiovascular disease, and cancer. And then I'll briefly talk about the future, about how do we move forward, and also briefly about my experiences being a Vasculitis Foundation Fellow. So there have been a lot of advances in the management of ANCA-associated vasculitis over the past few decades. The ANCA test became more widely used in the 1990s, which led to an improvement in disease detection. And there were a lot of clinical trials looking at therapy, and in particular looking at cyclophosphamide, whether shorter versus longer duration of cyclophosphamide was as effective. And we found that, yes, in fact, shorter duration of cyclophosphamide is as good as longer durations in achieving remission. And there's also new therapies that have come out and other new therapies that are under investigation. And through the Vasculitis Foundation and through other networks, there's been growing awareness about vasculitis. And even within the healthcare community, more and more people are learning more about this disease and coming into encountering it more. But have any of these advances led to an improvement in long-term outcomes, not just short-term remission, but long-term survival, end-stage renal disease? And this was kind of the main question that I wanted to know. So in order to answer this question, I had a wonderful opportunity to work with a group from the University of North Carolina using their ANCA registry, which was created through the Glomerular Disease Collaborative Network, or the GDCN. This began back in 1985, and it's a collaborative venture of over 600 academic and private practice nephrologists or kidney specialists, and patients are primarily located in the southeastern United States. We included all the patients who had a positive ANCA test and a kidney biopsy that was consistent with vasculitis, and a diagnosis between 1985 to 2009. We then divided the groups up, the patients up into 5 groups based on the year they were diagnosed. And again, we wanted to know, are those being diagnosed later in 2005 doing better or the same as those who were diagnosed in 1985? So our main outcome was to look at the development of end-stage renal disease, which is either the onset of dialysis or a kidney transplant, or whether they died. I'm going to call this ESRD-free survival. Another outcome we looked at was relapse. So here are some of the characteristics of the patients when they were diagnosed. There were over 500 patients who were included in the study, which is really quite a large number for a rare disease. The average age was about 60, although the age ranged from 7 or 8 years old to 92. Half the patients were female, and majority of patients were Caucasian and had MPO, ANCA, and microscopic polyangiitis. And this is reflective of the fact that MPO, ANCA, and MPA are more associated with kidney disease. And we found that there was no difference in these characteristics within those 5 time periods, which is important because if we're going to compare outcomes, we want the groups to be as similar as possible. We also looked at the organ manifestations when they were diagnosed and found they were similar across the time periods. So again, all of these patients had kidney involvement, about half had lung involvement, and there were a variety of other organ manifestations. However, what did change was the kidney function at diagnosis. So if you see the graph on the right, you see on the vertical axis glomerular filtration rate, which is a measure of kidney function. And the higher the glomerular filtration rate, the better your kidney function. And then on the horizontal axis is the time period that they were diagnosed. And you can see that patients who are getting diagnosed later are having better kidney function at the time they present, which suggests to us that we're picking up disease sooner before a lot of damage can accrue. Oops. We also found that more and more patients are receiving cyclophosphamide for treatment. But while more patients are receiving cyclophosphamide, the actual duration of their cyclophosphamide is decreasing over time, and this is probably reflecting changes in practice due to those clinical trials showing that less cyclophosphamide was just as good as a long duration of cyclophosphamide. So in order to determine whether these changes were leading to improvements, we compared these 5 groups, and we found actually that ESRD-free survival is improving. And this is really a big key point of the research we did. And I really want to kind of go into this figure just to explain it a little more. So you see here on the vertical axis is a proportion of patients who developed end-stage renal disease or died. And as we move across the horizontal axis over time, every time someone had an event, they went on dialysis or they died, the curve shifts down so that the lower the curve, the more patients who have either died or developed end-stage renal disease. And we're finding that patients who are diagnosed in 2000, shown in the green line, are more likely to survive and preserve their kidney function compared to those who were diagnosed in 1985, for example, which is shown in the black line. And this is really big. I mean, we sometimes take these things for granted in medicine, but this is a really phenomenal finding. And these curves have adjusted and accounted for differences in age and ANCA type and kidney function and cyclophosphamide use. So despite all those things, patients are continuing to improve in terms of survival in end-stage renal disease. So just drive this home again, compared to 25 years ago, patients diagnosed today are more likely to live longer and preserve their kidneys. We then wanted to know, well, why is this happening? Is it because we're detecting disease sooner, or is it because we're using less cyclophosphamide? And without going into the details of the analysis, we basically found that it's because we're detecting disease sooner. So the better your kidney function when you are diagnosed, the better your outcome is going to be. We then looked at relapse, and unfortunately the outcome with relapse is not as good. We're finding that relapse has not changed across these time periods, but at least it hasn't worsened. But certainly relapse is still an area that we need to focus more research on to see how we can do a better job of controlling disease. Now kind of moving on this theme of relapse, to talk about, well, who is at risk for relapse? Well, in truth, everyone is at risk for relapse. We don't have a cure for this disease. Doesn't mean you'll definitely have a relapse, but it's still possible. We also know that ANCA and disease type can help identify those who are at higher risk of relapse. So if you have a PR3 ANCA or you have a diagnosis of granulomatosis with polyangiitis, formerly known as Wegener's, you're at almost a double risk of relapse compared to MPO ANCA and microscopic polyangiitis. A prior history of relapse also puts you at higher risk of another relapse. And certain organ manifestations are also associated with more relapse, including sinus involvement and nasal involvement. So as physicians, when we are approached with someone who's having symptoms concerning for relapse, what helps us to think about it is to determine what is not a relapse. And one thing that is not a relapse that can mimic a relapse is damage. So an analogy to this would be if vasculitis was like a fire, there was a fire and you put the fire out, but now there's some charred wood and some smoky odor in the room, and it might smell like there's a fire, but there's no actual fire going on. An example would be, in neuropathy, if you have nerve involvement from your vasculitis, you may have kind of permanent numbness and tingling in your hands, and that could wax and wane over time. And even if it seems to be getting worse for a little bit, it might not actually indicate active disease. It might just be a marker of damage to the nerves. Another example might be nasal crusting. We can often see patients who have just persistent nasal crusting, not due to active disease, but really due to the damage that's occurred. Another mimic of relapses are infections, and this can often be very difficult to discern from vasculitis relapse, but it's important for us to think about and rule out when we examine patients. And another possibility is a medication side effect. An example of this might be the development of red blood cells in your urine called hematuria. If we see that, it could either be a marker of inflammation in your kidneys due to the vasculitis, or it could be a result of bladder complications from cyclophosphamide use. And the treatment of those two things are drastically different, and it's important for us to distinguish those. So we often start maintenance therapy, which is really preventative therapy to prevent future relapses. And this is often started after you've kind of gone into remission and gotten the disease under control. I'm not going to go into details about maintenance therapy, but really the types of maintenance therapy we use include azathioprine, methotrexate, and rituximab, and these are often our first-line treatment choices. Mycophenolate is a second-line agent. It was found in a trial to be less effective than azathioprine. However, we do use it, and I have seen a lot of patients who've done quite well on mycophenolate. Something I did not include here is low-dose prednisone. So for the most part, we really try to get patients off of prednisone. However, there are occasions where a little bit of prednisone can really help with some of those annoying symptoms, maybe sinus symptoms or nasal drainage, and we have to think about balancing those risks and benefits of prednisone. A question I often get is, how long do I have to be on these therapies? And when we think about this, we first assess your baseline risk, and this kind of goes back to a few slides earlier. So for example, if you are PR3 positive and you have a history of relapse, we might be more inclined to keep you on maintenance therapy a little longer because your future risk of relapse is higher. We also think about the extent of damage that has occurred and how much can you afford to lose. So if you have advanced kidney disease and another hit to your kidneys can put you and tip you over into dialysis, we might be more inclined to keep you on maintenance therapy for longer. Medication tolerance and toxicity is a consideration, and patient preference is also important. So there are times when patients really just hate medications. They really want to come off of it, and they're willing to take the risk of another relapse. On the flip side, there are those who can't afford to have another relapse. They really don't want to be on high-dose prednisone if there is another relapse. They really can't take another day off of work, and they're tolerating their maintenance therapy really well. So often in those cases, I think it's reasonable to continue the maintenance therapy for longer. So I just wanted to give a couple of practical tips for patients when thinking about relapses, and this is not really meant to be anxiety-provoking, but really just to give you some information and to empower you when you're thinking about this. So one suggestion I have is to make a diary. We can't remember things that happened weeks ago. You see your physician 4 weeks after the event happened. It's hard to remember all the details. I can't even remember where I parked half the time. So it's nice to write things down. And a little mnemonic you could use is this OPQRST. O is for onset. When did it start? Was it sudden? Was it gradual? P is provocation or palliation. What makes it worse? What makes it better? Q is for quality. If you're having nasal symptoms, what color is the drainage? How bad is it? If you're having pain, is it sharp, throbbing, dull? R is for region and radiation. Where is it located? How severe is it? And for time, how long has it been going on? Another a big kind of pet peeve of mine is really to avoid starting steroids before talking to your rheumatologist. So a lot of times, you might have a fever and a cough, and you might be seen in urgent care or by your primary care physician, and it's kind of this reflexive to start antibiotics to treat a potential infection, and then to give you prednisone to treat a potential vasculitis flare. And I understand kind of it's well-intentioned, and really the hope is to make the patient feel better. But often a week later, we'll see these patients, and they're feeling great, and we have no idea whether it's because they got antibiotics and they had an infection, or it's because they had a flare and they got prednisone. And certainly if it's a vasculitis flare that has very long-term implications, including perhaps more prednisone, changing your therapy, starting you on new therapies. And so it's very helpful for us to at least talk and examine you before we start steroids to see if we can discern what might be going on. Another thing that's helpful is to take pictures. So if you have a rash or anything visible, a little swollen finger, or anything, take a picture. A picture, say 1,000 words. Regular doctor visits and monitoring is indicated, obviously. And even if you're feeling great, it's good to get your lab tests done and for your doctor to see you, because it's good for them to know what you look like when you're feeling well. Now, there's some controversy over whether to repeat the ANCA test. The ANCA test is great for diagnosis, but its utility in actually predicting relapse is still very uncertain. And by and large, we don't feel that a rising titer in your ANCA is by itself alone to indicate a future relapse. It's not reliable. And so we often go based on signs and symptoms, and oftentimes we actually don't repeat ANCA tests at all. But that's something that kind of comes up a lot. When in doubt, seek a second opinion. We're at Penn, we're a major vasculitis center, and a lot of times community physicians will send patients to us for a second opinion just to kind of check in and make sure things are going appropriately, and I think it's a great partnership. Stay educated, as you all are. Lots of studies show the more patients are educated about their disease, the better their prognosis and outcome. And you know yourself the best. There was a study that went back and looked at a clinical trial and found that patients can actually pick up their relapse weeks or months before their physicians can. And so when a patient comes in and tells me, these symptoms feel a lot like when I first presented, I take that seriously, and I'll, make sure to monitor that patient carefully. Okay, so moving on to cardiovascular disease. So this has been a really hot topic in rheumatology. There's been a lot of kind of research showing chronic inflammation is linked to cardiovascular disease. And within ANCA-associated vasculitis, we also know that there's an increased risk of cardiovascular disease compared to the general population. It's the main cause of death after the first year from the diagnosis, and is possibly related to inflammation from the vasculitis. So how to reduce your risk? Well, nothing magic here. It's pretty much what we tell all of our patients, which is to make sure you see your primary care doctor regularly, to monitor your blood pressure, your cholesterol, and be checked for diabetes. Also, you can talk about your primary care physician about whether you're a candidate for aspirin. And healthy diet and exercise is always going to be helpful. Other things we think about is really to minimize the use of steroids whenever possible. Steroids are associated with high blood pressure, with diabetes, and among other things. But at the same time, we want to keep the inflammation under control, so we have to really, it's a balance of what to do with the steroids. And then moving on to cancer. Well, what do we know? Well, unfortunately, the bad news is that there is a higher rate of cancer in patients with ANCA-associated vasculitis. However, the good news is that the rate of cancer is decreasing, and we really attribute this to using less cyclophosphamide, and certainly bladder cancer has been decreasing over time. The other good news is that most of the cancer is due to non-melanoma skin cancer, which is annoying but not generally life-threatening. So what can we do? Well, we're already using less cyclophosphamide. Something I didn't put here was really is not to smoke cigarettes. So cigarette smoking, tobacco exposure is associated with bladder cancer and other cancers, including cardiovascular disease. So certainly, if you're smoking, stop, and if you aren't, then don't start it. Undergo age-appropriate cancer screening. So make sure you're seeing your primary care doctor. Again, this is another plug to have a good primary care physician. And if you're over 50, don't put off that colonoscopy. Get your mammograms and do all the appropriate age-appropriate stuff. You might also consider using sunblock and routine skin checks with your dermatologist. And if you're someone who's at high risk, maybe you're fair-skinned, you live in an area that has a lot of sun exposure, you might want to consider this. And just moving forward, so this is what we hope is in our future. So going back to the graph showing outcomes, how outcomes are improving over the past 25 years, we're hoping that if we are to continue, this is the trajectory that we're going to go on. And how do we get there? Well, it's through these things, which coincidentally is also on the Vasculitis Foundation logo. But it's through increasing awareness, research, and support. And I think all of these have been crucial in improving the outcomes that we've seen already. And I guess just briefly to talk about my experience as a Vasculitis Foundation Fellow, I really feel so privileged to have this opportunity. I'm starting my second year now, And it's been a tremendous time where I can learn about vasculitis and learn about the management, see lots of patients with it, and also do some research. And certainly as a young investigator who's studying a rare disease, it's not always easy to get funding, and the Vasculitis Foundation has really given me an opportunity to delve into this field more. And also just collaborating and networking with others in the field, other people who are doing research and who are treating patients with this disease. The more we work together, I think the bigger steps we can make in moving forward. And so really that's it. I just wanted to thank my mentor Peter Merkel, Dr. Landis, my statistical advisor, Dr. Falk, Susan Hogan, and the group from the University of North Carolina, all the patients who are enrolled in GDCN and participate in the research, and of course all of our funding sources. And that's it.
Great, Dr. Reed, thank you so much. Very interesting process. Working through all the data. You know, years and years ago, we didn't know how patients would do. So thank you so much for your work on this. We have a few questions from the audience, and I wanted to remind the audience that if you have a question in the right-hand corner of your screen, you'll see a question box. Just click on that, and then you can post your question out, and we'll ask Dr. Rhee, and we'll walk through the questions. So one of the questions was, are there any persons using rituximab? And so can you address that, Dr. Reed? Do you have any idea of the statistics on the number of patients using rituximab these days?
Ooh, I'm not sure the statistics on that. I'm not sure if they are also referring to some of the research we did. In the research we did using the GDCN cohort, some of these patients, a very, very small few, maybe a handful of patients might have received rituximab. And we specifically chose the time period to be before rituximab was approved, because certainly that is going to be a game changer in terms of some of these outcomes. So it certainly would be very interesting to see if we were to continue some of these studies in the future to see how outcomes have been changing after the introduction of rituximab.
Great, thank you. Another question is, if you are diagnosed with GPA without kidney involvement, are there statistics about how likely you are to develop kidney issues over time?
So it is actually possible to develop kidney disease if you don't have it initially, and so we do monitor for that even if you've never had a history of it. However, it's less likely. So oftentimes when patients have relapses, they're quite similar to their initial presentation. So I'm not giving you exact numbers, but I mean these are kind of general findings that we've seen.
Hi, we turned the questions over to Kaylin. Dr. Rhee, were you able to hear that question?
Oh no, I didn't hear it.
No.
Okay.
Okay. So the question is, for GPA patients in remission who have had renal involvement, how important is monitoring SED rates after remission has been achieved?
Okay, so well that's a good question. So kind of like the ANCA test, I think the sedimentation test, sedimentation rate and other markers of inflammation can be helpful as part of the picture, but we also don't rely on it solely because there's a lot of things that can make your sedimentation rate go up. Infection, any type of inflammation can make it rise. If you have actually chronic kidney disease, that can also make your sedimentation rate higher. So We check it sometimes because if you're having a lot of symptoms and then your SED rate is shooting up, all of the pieces of the puzzle together might help us kind of identify if it's a relapse. But a sedimentation going up by itself in a patient who's feeling otherwise well, we really are not going to, we really don't suggest acting on that because it might not actually be clinically meaningful.
Great, thank you so much. So another question that we received is, can you recommend nutritional diet that decreases inflammation?
So this is definitely a question we get a lot. There are a lot of things out that patients have heard about, low antigen diets and other things. None of these have been studied, and so there is no research actually that supports any type of diet modification that can help reduce inflammation. So my advice is really that I would just keep a well-balanced diet, just fruits and vegetables, but I wouldn't go crazy doing some of these intricate diets because we haven't found that it's made any benefit.
That's interesting. That's actually one of the questions we receive a lot as well through the Vasculitis Patient-Powered Research Network, and one that we see commonly among some of our social media groups. It's in conversation quite often. So thank you for sharing that. And how important is the PR3 lab to relapse in GPA?
I'm not exactly sure what the question is referring to. Is it perhaps in terms of the initial diagnosis of the initial ANCA test done is PR3. PR3 is associated with a higher risk of relapse, and again, these are not absolutes. Doesn't mean you're definitely going to relapse. It's just that on average, all of the patients who have PR3 are more likely to relapse than those who are MPO ANCA. But if it's, I'm not sure if the question is referring to that or if it's referring to repeating the PR3 and determining whether that might indicate an imminent relapse. And to answer that question, we again don't find that repeating those ANCA, PR3, MPO titers is at all predictive of relapse. There's been actually a lot of research done and a huge meta-analysis done to ask this question, and we're just finding negative results. We're not finding that ANCA tests are enough to predict a relapse. So we don't check it, we don't repeat it. Certainly there might be a group of patients where it can be seen to associate with disease activity and relapse, but at this point in time we don't know who those patients are, and it's just not a reliable test. So we like to focus more on symptoms. It's sometimes nice, these questions about sedimentation rate and the ANCA test. We so wish we had a single blood test that can just give us a number and tell us yes, no, whether there's going to be a relapse. And trust me, there's lots of studies out there trying to identify that marker that can help do that. But unfortunately, things are so complicated that at this point, we're not finding that these tests are reliable enough to predict that.
Okay. So one of the other questions, and this is one that we've received several times as well, it's about rituximab. So are there other options? Is there anything out there other than rituximab? So there's this kind of fear that if rituximab is the end of the line, what happens if it doesn't work, or are there other options?
So this is an interesting question. I mean, there's a lot we can still do even with rituximab. So certainly if you've only received rituximab and you flare rituximab, then we would switch you over to cyclophosphamide, and that can be an option. If you flared on cyclophosphamide and you're flaring on rituximab, there are other considerations. For instance, there are patients who tend to have a lot of relapses, and they're getting regular rituximab, and we may increase the frequency of rituximab, give it more often, rather than just every 6 months, maybe give it even every 4 months, sometimes increase the dose. So there are ways we can kind of play with the rituximab. This is certainly not based on any good data or evidence, but it's simply kind of just trial and error a bit. You know, and then if I have not honestly seen a lot of patients who just not doing well with anything, either cyclophosphamide or rituximab. I mean, it does happen, but certainly like plasmapheresis, you know, doing other types, giving you other maintenance, other drugs, other immunosuppressives are possible too. Thankfully, I don't think this is a major problem. There are a lot of new drugs actually that are being studied today, completely new drugs that are not even available, that are under investigation. So I think in the next few years you're going to be hearing about new therapies that we can use for treatment of vasculitis.
Great. So that's a hopeful response, that we can work on individually and that there are several options. So another question is about, is there any data on the percentage of patients who relapse and the average time of relapse after an initial remission from MPA?
Okay. So there's a lot of different literature out there. For MPA, and I'm going to specify with MPO, ANCA, MPA, the rates of relapse have been roughly maybe 20–30% within, you know, the first year or two, and certainly relapses are more likely to, if they occur, are more likely to occur within the first year or two from diagnosis. So that's often why we like to continue the maintenance therapy for that period of time. We find that the longer you go without a relapse, the less likely you're going to eventually develop a relapse. And then in terms of long term, we don't actually have a lot of data going beyond 5 years, because we really, unfortunately, just a lot of the studies are limited in following enough patients for that long. Sometimes patients who are doing well tend to drop out of the studies, and then we kind of lose track of them. So, but certainly our feeling is that the rates of relapse are higher in those first 2 years, and then afterwards it really declines.
So with that being said, do you have a recommendation for, is there a way that patients can become more engaged in the process of research or help contribute to research?
Yeah, I think there's really a lot going on, and I, you know, have to give a plug for the Vasculitis Foundation, really, because I think the Vasculitis Foundation is just phenomenal and doing so many wonderful things, and partnering with physicians and researchers. I think, you know, if you are interested in being involved, I think become a member of the Vasculitis Foundation. You'll get lots of emails and messages about the research opportunities that are available. And talk to your physician, who, you know, your rheumatologist, your nephrologist, whoever is taking care of you, and they may also be able to give you some guidance on whether there's research going on at their practice, or if they know of other practices that are involved in research. And just another plug for the, you know, Vasculitis Foundation is the VPPRN, which is becoming really has launched and is growing in numbers, is another great opportunity for patients to be actively engaged in research. And this is the future. I think that we're seeing patients do so much better because because of the research that's been done, and so this is our hope, is that one day, you know, we won't even be talking about relapses. So, yeah.
Great, thank you so much for that. It is one thing that we are trying to do at the Vasculitis Patient Powered Research Network, as well as the VF, is promote ways for patients to participate in research that is easy for them and accessible, and still provides this much needed data, so that researchers and physicians like yourself can help find better treatments, better diagnosis, procedures, etc. So there is another question about labs, actually, kind of going along with this this theme of needing more information. So if the labs aren't telling us if we're flaring and are only good for diagnosis, should we continue to follow up unless we're feeling badly? And how likely are relapses to be more severe?
So I think, yes, you should be following up even when you have been healthy for years and years. And I think that some labs, so for instance, a sedimentation rate, again, is useful in the context of your symptoms. But an example of something that is really helpful is a urine test. So the urine tests pick up inflammation in the kidneys long before you start having any damage to your kidneys. And that's the time when we need to kind of intervene and start treatment. So kidney disease is really the silent asymptomatic, it's asymptomatic manifestation. You can't feel when your kidneys are bothering you. If you have a sinus problem, you can tell. If you have hearing issues, you can tell. But if your kidneys are actively inflamed, you will not feel it, and that's why getting regular tests to, you know, check your urine test, check your kidney function, it's very important. If you're on certain maintenance therapies, azathioprine, methotrexate, for example, you need to be getting regular lab monitoring anyway, just to monitor for any drug-related side effects. So, and again, I think it's good for you and your physician to see you. It's good for your physician to see you when you're doing well. It's helpful. I mean, the more time points we have when we get a sense of this is what this person is like when they're not feeling well, and then they come in 3 months later and they're not feeling well, you know, it helps to compare. And you know, I can remember, oh yeah, 3 months ago your lungs were perfectly clear, and now they don't sound good. I think it's important to be engaged in with your healthcare professionals.
Great, thank you. So then the final question before we wrap up is one about the long-term use of prednisone at a low dose. And so the question is it possible for someone to be on a low dose of prednisone for forever, or is there some kind of lifetime, is there a limit on that and its effectiveness?
I think for the most part, we think that prednisone at doses less than 10 milligrams, you know, I'm giving a little ballpark, certainly 5 milligrams or less, doesn't carry the same long-term risks as higher doses of prednisone. I think we prefer patients not to be on any because if we can minimize any type of small chance of you know, of any side effects, we'd prefer that. But if you really are having a lot of symptoms that are just impairing your quality of life, if it's not enabling you to, you know, go out with your family or, you know, go to work or do any of the things you enjoy, I think that we kind of feel that maybe sometimes little low doses are reasonable. In terms of duration, it's really hard to tell, you know, but you know, there are patients who are on these low doses of prednisone for years and years. But I think that if there is a point in which you can try to kind of come down on the dose or come off of it completely, it should be something that you aim for, and really something you should try to do. One thing we definitely don't give prednisone for is fatigue. So fatigue is often a big issue among patients with vasculitis, and prednisone really is not a good answer for that. It's just it's it's everyone's going to feel a little better on prednisone, and I don't think that that's going to be safe in terms of long-term consequences. So that's just kind of my stance on that. But yeah, I mean, certainly there's patients who are on little bits, 5 milligrams of prednisone for a long time, and I think that's fine.
And Dr. Reed, thank you so
Great.
much.
Thank you again. Dr. Reed, thank you so much for speaking today and sharing your knowledge and expertise with us. We very much appreciate it. And thank you for being our fellow. We are just so happy to have you as a fellow. The VF is committed to helping train our younger physicians, investigators in the field of vasculitis. We just think it's so important to train more people who will be able to help our, not only our patients today, but patients in the future, the newly diagnosed, the people who are waiting for diagnosis, etc. So thank you for your work.
Okay, thank you.
We did record today's webinar, and we'll be adding it to our webinar library once it is edited. And if you've missed any of our previous webinars over the past 8 months, you can also access the webinar library on the VF website. If you have a suggestion for a future webinar topic, please feel free to contact me and let us know. Or, one thing we're asking is if you've heard another speaker, if you've seen a webinar or seen a speaker at some meeting that you thought would be interesting for the group to hear, please forward their name and contact information to me, and we'll try to get them scheduled also. I'd like to invite you to join us for our next webinar on Monday, August 24th at 12 o'clock noon Eastern Time. We're very pleased to be welcoming Dr. Phil Sayo, who is the director of the Johns Hopkins Vasculitis Center in Baltimore, to be our guest speaker. Dr. Sayo is giving our Back to School webinar and is going to be discussing issues of interest concern for our pediatric patients and our young adults who will be returning to school. One of Dr. Sayo's patients is going to be joining him on the webinar, so they're going to be doing a tag team. So I know that this issue won't be of interest to all of our patients, but we hope that those with pediatric patients, our parents of patients with our pediatric patients will be able to join us. Our young adults, he's going to be addressing issues such as medication compliance when you head off to college. He's probably going to be discussing drinking, whether to do it or not. We're just trying to reach out to our parents and the pediatric patients and the young adults. So please join us on Monday, August 24th. And we'll be sending out an invite for the webinar and posting it on social media. Finally, I would like to thank all of the attendees today. Thank you so much for joining us and helping make the webinar a success. We hope you have a great day. Thank you very much. Have a great day.